So this brings us to our speakers panel, where all of today's presenters will gather on the stage for a question and answer period moderated by Dr. John Esdale. So up you come, and I guess we'll pass a mic back and forth. John has tons of questions here, which he will organize.
Yeah, well, the panel is coming up. I'm going to just read them the Riot Act. The answer, we've got a lot of questions, and more are arriving. To get through as many as possible, we need to have very short answers, and yes, no, and maybe are an answer. You don't, scientists like to, give every side of every aspect of everything, and they're not allowed to do that. Now I'm going to start off with Nick Bansback. We're finding the two microphones. I notice he's holding it. Nick, is it scientifically proven that surgeons are usually overly optimistic about the positive effect of surgery?
Yes.
Thank you. I gave a nice starter warm-up question.
We're overly optimistic about our success of surgery, and we underestimate the chance of harm from surgery or side effects.
Thank you very much. A question just arrived. What is the usual age of onset for lupus? Somewhere between 20 and 35. 85 to 90% are in women. Another one for Nick Bansback. If I want to get the bigger picture for decision-making and not just anecdotal information, where do I start?
You should be talking to your doctor is the first person that you should be starting with. It's much better to be talking to your doctor than just searching on the internet. But there are other resources available, but hopefully your doctor or the arthritis website will be able to guide you to them.
Thank you. Michael, people I know with knee pain or OA tell me they have bad knees and have difficulty on the stairs. I don't have difficulty on the stairs. Is this a myth?
No, it's not a myth. It's a very common complaint.
Yeah, thank you. Would there be any advice on the treatment of Baker's cyst? I'm going to answer that, or Michael?
You can answer it.
A Baker's cyst is a cyst behind the knee, often arising from osteoarthritis or an inflammatory arthritis. If it's symptomatic and problematic, a cortisone shot in the knee probably takes care of it 95% of the time. See your favorite arthritis doctor or your family doctor or whoever. Michael, can compression tights be helpful for knee stability when running?
Maybe.
Maybe. That's good. That's good.
I think they're better than nothing, but they're certainly not as good as general overall strengthening or some of the, the more custom knee braces that we were discussing earlier.
So localized compression. For Mark Harrison, have there been any studies on nutrition and lifestyle interventions for preventative health in at-risk arthritis populations?
Yes, I think there are. I don't know about them particularly, but they exist, and people often prefer those types of things before going on to drug treatment. So yeah.
Thank you. Dr. Mary DeVera, are there any medications that are are there any medications other than biologics that are safe for treatment of arthritis during pregnancy?
Hydroxychloroquine is considered safe. That's one of them, and they're commonly used in pregnancies.
Yeah. For sulfasalazine, hydroxychloroquine, prednisone, even though we don't like to use it, is safe. Michael Hunt, a man very popular here. Where would someone go to get a gait assessment?
You can talk to Natasha. So Natasha is the research coordinator in my lab, and we run a number of studies all the time, and a big part of those research studies is gait assessment.
Mark, here's an interesting question. How are you going to get the information from your research out to clinicians and policymakers?
Oh, that's a good question. We have many links with BC Ministry of Health and other decision makers. I sit on some of those committees for the Ministry of Health as well. And then we've got a huge network through Arthritis Research Canada to target clinicians. And I also partner with Joint Health, who've got a huge network and influence at anything from policy to clinical action and patient education and information. So.
Great. Nick, does your study include people having second-time surgeries who've already had a knee replacement?
It doesn't yet.
Not
That's
yet.
a more complicated decision. We're just targeting the first decision at the moment. But we will get there.
He's going to get there. We'll have to have him back to get the answer. This is a question for me. If you use biologics for RA, how does that interact with other autoimmune diseases? That's an interesting question. The answer is we don't fully know, but many of the biologics, say an anti-TNF, will work for rheumatoid arthritis, psoriatic arthritis, spondyloarthritis, while a different one, an anti-IL-6, would work for rheumatoid arthritis and giant cell arteritis. So depending on the biologic, they may work for a variety of different diseases. Generally, we don't give two biologics because, at least so far, that hasn't worked out well. Can you hike with early OA?
Can you what, sorry?
Can you go hiking with, but it's specifically with early OA, the question.
Absolutely.
There you go.
Short and sweet.
An extra answer? No? No? You can do it. You should be doing it within reason. Stem cell or other treatments for the hip, when will these alternatives be implemented? Or synthetic cartilage for the hip? Oh, it's for me. I was wondering who's going to answer this. Okay, the Canadian Academy of Orthopedics has come out and said there's not a shred of evidence that stem cells work right now. The American Academy of Orthopedics has come out and said there's not a shred of evidence that stem cells work right now. There are studies ongoing. Osteoarthritis is very placebo responsive, but if you're interested in that particular placebo response and have $4,000 US per knee, you can go down to somewhere like Palm Springs and have a holiday and do it. Synthetic cartilage is not working yet, but it's obviously more of the same. It's of great interest. Catherine, do you have anything suggesting avoidance of foods with regard to diet for reducing inflammation?
No. There are some suggestions about specific foods, but you'd be best informed to use Dial Dietitian and have a chat about your specific situation with a nutritionist.
Thank you. Some foods may be anti-inflammatory, omega-3, turmeric, and everyone should make sure they're getting enough calcium and vitamin D so that they don't break their hip. Michael? Oh.
There you go.
No, sorry, same question. Some of the questions are longer than others. Okay, that's Michael. What is the effect on your foot and ankle? Oh, well, I think we've covered does anyone still want to know more about the effect on the foot and ankle of an orthotic? I think that, yes, okay. Anything to comment on the orthotics for the foot and ankle on the arthritis?
Yeah, so I think that's a good point. So not to go into too much detail, but there is a growing body of evidence to suggest that foot and ankle problems do have a pretty strong link with knee osteoarthritis. And so depending on the type of orthotic we're talking about, it may have either a beneficial effect or sometimes a detrimental effect on the foot and ankle. So when you're talking about orthotics, it's always best to go see a professional, a podorthist or podiatrist to ensure that the foot and ankle isn't being ignored.
Great. Now, Michael, hold on. Are orthotics and footwear only helpful for knee problems, or can they be used for hip joint problems?
Yeah, that's a great question, and I didn't address this in my talk. I would say that they are helpful for not only foot, knee, and hip problems, but they're also helpful for many other types of arthritis, not just osteoarthritis. To help people moving into to unload and offload some of those painful joints.
It sort of sounds like maybe they're underused.
Very much so.
For Mary, I've heard women with RA can go into a type of a remission during the pregnancy. Is this true? And would you continue on biologics during that time?
I think historically, they've been shown that RA goes into remission during pregnancy, but there's actually recent data that shows that it doesn't. I think Dr. Estelle can confirm that. And I think based on the evidence, that biologics are safe and it doesn't lead to these adverse outcomes, I would recommend, because disease control is very important to have a safe pregnancy.
The downside is if you stop your medications, you may remain in remission during the pregnancy, but then 6 weeks after the delivery or a little later, very often you'll go back, you'll have what's called a flare-up in the disease, and that's when mothers are breastfeeding and maybe not feeling totally 100%, so that often the drugs are carried through knowing that there's going to be problems if they don't a couple of months out. I think, how long do knee replacements last? Okay, is that Nick? Who's going to do that?
It's that they're improving over time, so that the data keeps improving. I think the latest I heard is around about 60% are still working after 10 years. So it does vary from individual to individual, but a number of people, they are lasting longer than 10 years. Though it is possible that you're going to require a revision to that first joint in that time.
All the more reason to do all of the things to allow you to put off that first one, if you can do it and still, function and be happy. Does biologic treatment increase or decrease heart disease? The lady I mentioned who was looking at heart attacks and so on has shown in rheumatoid arthritis, as have a number of other scientists, that there appears to be a decrease in heart attacks in people with rheumatoid arthritis taking a biologic. The major increase in deaths from inflammatory arthritis like rheumatoid arthritis is due to cardiovascular disease, so heart attacks and strokes, and that probably explains the improvement. I'm not sure who's going to answer this question. The provincial government had pledged to reduce wait times for hip and knee replacements. I've been told I'll have to wait a year to see a surgeon and then 6 months for the surgery. Please help me understand the wait challenge.
Yeah, the weight challenge is because of the 20% increase in demand for hip and knee surgeries over the last 5 years. And meeting that increased demand, we haven't built new hospital rooms, the number of surgeons. It takes time for these things to increase to meet those demands. So the new money that is being put in by the Ministry of Health is going to be trying to increase the number of surgeries, but also look at how they can manage and help patients who haven't fully utilized non-surgical management, help utilize those so that perhaps even whilst you're waiting, you're still in less pain whilst that wait happens. But the plan is for that wait time to come down with increased resources.
So two things. I just want to add that it's not a bad idea to write your MLA and the Minister of Health and the Premier that I've had these people tell me, they don't really care what you think, Dr. Estelle, because we know we can wipe you out in the press. We worry about patients. So they're much more likely to worry if you write, because they, nationally, if you write, they consider it 1,000 votes, provincially 100 votes in their writing, and get a few of your friends to write. And I think the point is, one needs better access to surgery, but one needs better access to help to avoid surgery. Okay. Here's the cortisone question. What is your opinion on taking cortisone shots? Are they harmful in the long run? How many can you take before they become harmful? And can they be taken by mouth? Anyone want to go for that? No, tricky. Okay, I'll try and answer it. The cortisone shots for very acute inflammation can be helpful, so that if you're giving, say, a cortisone shot for someone with acute bursitis of the shoulder. They tend to do very well. In the knee, where they're often used for osteoarthritis, a good outcome would be they help for 2 months. And certain types of tenosynovitis, like your finger locks, they can be dramatically beneficial for years. I don't think there's one answer fits all. That one of the benefits of a cortisone shot is that if someone does get better, even only for a couple of months, it's an opportunity for physiotherapy, for exercise, for a whole pile of other things to start that might not have started quite so easily. And the same for shoulders, and for some things like the locking finger joint, I think it can be really dramatic. For people with end-stage osteoarthritis who are waiting surgery, I'm willing to give them quite frequently just because I'm not worried about damage. They're going to have that joint removed and replaced, and it's just a matter of trying to make life a little better while they're waiting for doctor surgeon. Now, here's a question for Mark. It's quite a complicated question. I'm curious to learn more about your interviews and the rank order between the side effects risk reduction. How are people's preferred roles, bracket, shared decision-making, autonomous or passive, close bracket, impacting the conversation with healthcare professionals around risk reduction, prevention, and treatment of RA?
Yeah, that is a complicated question. So just to sort of give a bit of background, which I didn't give in the talk. So when we try and understand people's preferences, we have this way of asking questions where for each person who fills the survey out, and some of the people who are watching may have done that, we don't name a treatment, but we give 2 alternative treatments which are described using those 5 features that we're talking about. They take different values, and then we make people make repeated choices, and through that process we can understand what's feeding into people's decision-making, so what's most important out of those features. The shared decision-making angle was something that came through really strongly when we talked to people when we were trying to design those surveys. So I think it's quite a complicated thing to put in there, but it represents that need for, and I think a need for a real conversation around that very difficult decision-making process. So we represented it quite crudely in that, so it could take on a lot of different aspects in reality, but we were just trying to represent the importance of at least having that conversation and that recognition that the other person's opinion is important in the decision. I think that's all I can say.
Okay. Thank you. That was the tough question. No doubt about it. A question for Michael. If you don't live in the lower mainland, how are you going to get a gait assessment? Who and where do I go?
Yeah, so I mean, I guess it depends on what the definition of gait assessment is, and there's multiple types that you can do. You could simply go to a physiotherapist, and they will assess your gait visually, and physiotherapists are very well trained in doing that and providing some advice. What we do out at UBC is with the machines and the technology that John was mentioning earlier. The problem is, and I think it alludes to the question, is that those types of facilities are very few and far between. There's one, there's one at VGH, there's one actually out here at the Fortius Sports Institute. I don't know of many others, if any, that are in BC. There's a couple in Alberta, but, in my opinion, sometimes more isn't always better. So going to a physiotherapist and just getting some visual assessment and some advice is good enough.
Right. So Michael is into the Cadillac of gait assessment, and to be honest, if you're just trying to get from A to B, a Volkswagen is pretty effective, and there are many physiotherapists who will help you with the puzzle. Okay, here's a good question for Catherine. Catherine has been the head of the Department of Occupational Therapy. How do you decide whether you should see a physiotherapist or an occupational therapist?
Okay, so I'm going to say what matters to you. So what is it that you need to do? So often you'll want to see both. They may refer from one to another, so you don't need to worry about choosing one or the other. An assessment by a physical therapist who determines that what matters to you and the things you're having difficulty with is more in the realm of OT will just refer you over to an OT and vice versa, but often you may benefit from both. So essentially, physical therapists are helping get you moving, and occupational therapists are making sure you can do the tasks that are expected or needed to do in day-to-day life. So Nat McKinnon, who is moderating the Twitter feed, has a favorite poster that says, so the physical therapist has got you up and walking. Are you going to go down that hallway naked? Didn't think so. That's when you need to go see the OT. So if you're having problems with those activities of daily life, so the things taking care of yourself, getting to work, school, doing things you love to do, then you probably want to see an OT. If there's some mobility impairments related to that, you probably want to see a PT. Sometimes you need both.
Thank you. When considering preventative testing, what age should this start? And is this test part of a normal general GP visit?
That must be me. The honest answer is I don't know. We're very the testing was slightly ahead of the work that we were doing. So we were kind of assuming that a test existed. Maybe you've been identified as being at high risk. What happens then in terms of treatment decision making? I think the fairest answer is to say that the testing at the moment is in its development. It's not perfect. It's not been rolled out. So there's two uncertain components to what we're doing. So the first is that testing, and then the second is what you do with the information that comes out of that test in terms of, do you try and intervene and prevent arthritis, or do you watch and wait?
Yeah, as opposed to preventative testing, just prevention, you will know more than most family doctors if you walk out of the room knowing that if you don't want to double your risk of rheumatoid arthritis and probably similar types of arthritis, don't smoke. And if you don't want to increase your risk of osteoarthritis by 400%, and I think the Brits say 700%, don't be obese. So that staying fit, keeping your weight down, not smoking, probably is a good starting point for everyone. All right, the last question. A patient somewhere with osteoarthritis is always cold, to the core sometimes. Can OA cause this, or is it due to a different disease? Anyone want to go with that? No? No? No. Oh, you can feel cold from certain diseases. I guess the most common is hypothyroidism. But I think one of the terrible things is people who are 60 are more likely to complain of feeling cold than people who are 15. One can remember children who are totally blue getting out of the ocean and still not even feeling cold. So I don't have an answer for you, but I think if it's really a change, if it's really severe, I definitely would mention it to your family doc. That's the end of the questions. Thank you all very much. And we have 1 minute left.